Hello again, everybody. My special internet friends. It's Tuesday. It's about 3:30 in the afternoon, and it's after work. My work is done, and I'm on my way home. Pretty average length day today. I only saw 4 patients, which used to actually seem like a lot when I first started. Getting 4 patients done during a shift was pretty challenging for me. Now that I've finally settled in and I've almost been, doing this hospice job for about a year or so, almost a year, maybe 10 or 11 months or so, 4 patients does not seem like that much, which is good. It means I'm getting better. Definitely after that 7-patient day yesterday, 4 patients does not seem like a lot. But it's taken me longer to do 4 because all 4 visits were really far away from each other, maybe like average of like 15 to 25 miles away from each other. So I've been doing a lot of driving. I've been driving all around the county, which I like. It's kind of fun. It's one of the things I enjoy about this job. I get to see different neighborhoods, and I've always liked driving around. I like it better when there's somebody in the car with me, which is probably part of the reason why I'm doing this. But I do like driving around and listening to NPR and seeing different people's homes in different towns. And I've got my GPS, so I know I'm not going to get lost. And it was a pretty good time. Everybody was doing good. Everybody was feeling fine, and there were some like minor issues to work out and like some things to adjust. And I had to like make a couple of phone calls to people. I was calling the volunteer office for one person, whose spouse wanted to get some respite services so he can get out of the house and do some yard work. Hell of a guy. Like he was like doing everything on his own, almost everything on his own. And all he wants is just like 1 or 2 hours to go do some yard work. Like that's his big concern. So I'm definitely hooking that up today. And I ran into another situation where a private duty caregiver gave a patient a 6 times overdose of methylprednisolone, which, if you're not familiar, you should look it up and then see how you feel about getting a 6 times overdose of it. So I was kind of concerned about that. I mean, the person was like feeling fine, and she had some symptoms yesterday of being like overtired, which doesn't quite make sense to me. So I called the doctor. I did the usual routine. Call the doctor, report the med error, get orders, which consisted of, just continue to take as directed. There was really nothing else for me to do about that issue. And then the private duty caregiver made a comment that I kind of half heard, out of the corner of my ear. And she said, "Oh, geez, I hope such and such doesn't find out," which is one of the daughters. So, of course, as soon as I got back into my car, the first thing that I did was call up that family member, who was really nice over the phone and understanding, and I explained what was going on. And there was, it wasn't an emergency. I just, had to tell her because I have to inform her, And so that's like the kind of mischief I get into during the day. Communicating with doctors' offices is kind of fun, although I really like talking to the doctors themselves better. And I'm finding that doesn't happen that often in home care. I'm usually handed off to a PA or an APRN, which I don't mind. They're really knowledgeable and they know a lot of stuff. I just think talking to doctors is fun. I'm giving them a hard time. And they give me a hard time, so it's fair game. It's a fair deal. That teaching project is tomorrow. I'm a little nervous about it. Maybe just the nervousness of excitement more than anything else. But I feel the way I usually do right before something like this. I feel underprepared. Because I guess I kind of semi-intentionally underprepared. Everybody at the office wished me luck, and a couple of people were surprised that I was doing it in service because I'm not full time there, and I'm relatively young compared to the rest of them. But apparently, one of my internet friends thinks that my beard makes me look like a hippie professor, which I guess was supposed to be some kind of compliment. But I'll take it. If the graying beard gives me that little extra, what's that word? Gravitas. Then I'll just run with that. And maybe I'll run into people that I know at this thing. I don't know. I don't know I haven't been to this particular nursing home in a long time. I think I swung by there once to apply for a job. But maybe it's possible that people that I know work there. That would be kind of a neat kick. And somebody from my employer is coming with me. I'm not sure exactly why. Maybe just to make sure that I don't say anything too outrageous. I guess, I'm going to be, in a way, I'm going to be representing the agency by going out. So I guess they want to send somebody to keep an eye on me and make sure I'm not too radical. Something I was thinking about including in this project has to do with some questions that I've been having personally about my practice, specifically about anticholinergic medications, specifically anticholinergic medications given at the end of life to control what I see referred to in the literature as terminal secretions. Also known as the death rattle, And there's a medication that we have. I actually, before there was a shortage of it, I used to keep a couple of vials of it in my home care bag. But it's called glycopyrrolate. Also, there's I think scopolamine works the same way, and then there's another one like hyoscine, I think, or something like that. But they're anticholinergic medications that are given for terminal secretions, and they work by reducing salivation. They also reduce upper airway secretions, not lower airway secretions, but they reduce upper airway secretions. And they also pretty rapidly neutralize your stomach acid as well, or decrease the production of your stomach acid. So they give it sometimes for ulcers and things like that. But my questions about it are manifold. There's a few different approaches to it. But for one thing, the drug doesn't clear any of the secretions that are already there. It just prevents more from forming. Also, the gurgling kind of death rattle that's being caused by serous fluid leaking into the bases of the lungs, or from the capillaries of the lungs. These drugs do nothing for that. They're still going to be there. The mechanism of action is totally different. It doesn't affect that part of the physiology or the anatomy or whatever. So, a lot of the times, I see it being given, and the only positive effect is, well, not the only positive effect, the only effect that I can tell that the drug is having is that the person's mouth gets very dry. Now, this is problematic because mouth dryness is one of those end-of-life symptoms that you really focus on because the only symptom of dehydration is mouth dryness, and having a dry mouth is uncomfortable. So, when people get large doses of these anticholinergic drugs, it's very difficult to keep their mouth moist because their mouth dries out so much because they're not salivating. They're actually starting to use this medication now for excessive drooling in certain types of cancer patients, I think. But they use it to decrease saliva, And then the other angle of this is that, it's really hard for me to find a lot of research on this. I thought a while back I found a reference to something having to do with EEG studies at the end of life, but anecdotally, certainly everybody that I've talked to agrees, who's in the end of life business, that this death rattle, these terminal secretions, are not a cause of suffering. They're not causing the person to suffer, mainly because at this point their awareness is greatly reduced. If they're weakened enough that they can't clear secretions at this stage, while they're actively dying, they're probably not very disturbed by the noises that are coming out of their mouth. And, they probably can't themselves hear it very well either. But it certainly doesn't seem to cause pain. It's not causing the respiration rate to go up, which is one of the things we look at for pain. Are they breathing faster, And it's, just like a normal part of the process, this sound that's caused by secretions in the airway that aren't being cleared, and air passes over them and it makes these sounds. So it seems like we're giving these drugs because we want the family to feel better. And in fact, when I've asked my elders and betters in the end-of-life business, that's exactly what they say. Well, it's really more for the family. And I found that very disturbing for people to say that. Why would I be giving a drug because of the effect it's going to have on somebody else? We have certain like ethical obligations and responsibilities to the patient, and one of those is not giving them unnecessary medications. And this same drug, glucopyrrolate or Robenal, it's also called. There is another use for it. People take it in pill form. But interestingly enough, these terminal secretions, specifically in cancer patients, you're more likely to have them with brain cancer than any other kind of cancer. I thought it would have been lung cancer, but this is not the case. Most likely to happen with brain cancer. So, it seems to me that the better thing to do would be to educate the families about how this is a natural part of the dying process and that it's not a sign of their suffering, rather than give them large doses via subcutaneous injection of a powerful anticholinergic drug. Now, the other thing the anticholinergics do also is make it harder to urinate. And I guess this is okay if incontinence care is painful for somebody, but dehydration is going to accomplish that anyway. So I don't think we can really, look at the benefits of the anticholinergics from that perspective. So I don't know. I'm really like, this is like kind of like a philosophical crisis for me, because it's very, very commonly given. We give it in the nursing home, we give it in home care. I've even established subcutaneous infusion ports into people at the bedside so the family members can administer this medication. And it's a long-acting medication, Robenal. I didn't know that till the pharmacy told me. That's why you usually only see it like Q6 hours or Q8 hours. And secretions will get really bad, and you want to do something for them. It's like, oh, well, let's give it to them every 3 hours. Let's give it to them every 2 hours. But, see, there's a problem with that, because, for one thing, if it didn't go away with the prescribed dose, it's not, the secretions that are there aren't going to go away from taking the medication. That's not what it does. It prevents them from making more secretions. And in a lot of cases, I found it doesn't even reduce the noise, which is ostensibly the thing that you're treating. It's like an acoustical medication. It's a medication that you're giving to somebody because of a noise they're making, not because of something they're feeling or because of something unnatural. Like, this is natural. This is what happens. This is what happens at the end of life. And I understand, like, family members not knowing this and needing to be educated about it, but it seems like it's everybody. It's like nurses and doctors and everybody else. And there's, you can look up all these articles. You can look up all these articles, like, about studies, about different kinds of these drugs, like scopolamine versus Robenal versus, hyoscine or whatever the other one is. And the way that they measure the effectiveness of the pharmacotherapy is how less disturbed the family is, right? Like, this is the objective way they're measuring whether or not giving this drug was a good idea, whether or not it was effective, And the way they're measuring this is how comfortable is the family, So, I don't know. Personally, in my own practice, I'm going to try to reduce the usage of these drugs as much as possible by assessing for symptoms and educating the family and those kinds of things, because I've seen people's mouths in a really horrible state because of these anticholinergic medicines, and I think we could do a little more to keep that mucous membrane intact. I think skin integrity should be like a really high priority. Well, I did some wound care today. Wound care is always fun. I don't always get to do wound care. There is quite a bit of wound care in home care nursing and hospice nursing. But it's like since I fill in for people, it's very uneven. Like, I never know when I'm going to run into it. So I got to do some dressings from a fall, and that's a lot of fun, because you got your medicated ointments, and you got your special non-stick gauze and your paper tape, and all of the fun ways to wrap up gauze dressings. I love wrapping up gauze dressings. I never learned how to do it before nursing school, but there's sort of a satisfying, like, combination of, like, engineering and arts and crafts and medicine that goes into it. because you want to wrap it in the right way, and you want to apply the dressing in a way that preserves the the cardiovascular system, and you want to recognize changes in the wounds, and you want to clean it using very meticulous technique. You have to be very disciplined with your hand hygiene and your supplies and all that stuff, and actually wrapping the thing up itself is a lot of fun. There's all sorts of different techniques that you can use to anchor it at different parts of the body and to secure things in place. And I think it would be kind of fun to be a wound consultant or something, but I don't want to specialize. I talked about that before. If I was to just specialize in wounds all the time, maybe I wouldn't necessarily get bored of it, but there would just be like a sort of a quiet ennui in the middle of my soul that I'm doing the same kind of thing all the time. So I'm going to keep trying to do as many different things as possible on a day-to-day basis, which both hospice and nursing home work are great for. I don't think I could ever get bored supervising a nursing home. That is quite an adventure. Maybe I'll spend a little time talking about that in another episode, since I can probably speak more freely about it now that they don't return my phone calls anymore. Unless it's an emergency and they really need like some help, then they call me. Yeah. So this project, I'm thinking I might have to. I don't know. I made a bunch of outlines already. I may just use that narrative as an outline and just kind of glance down at it to like refresh my memory about like what I'm doing. Who am I? Where am I? What am I doing? Oh, that reminds me. I did a memory health assessment, which we don't do that much in this job, but out of curiosity, it was a dementia patient that I'd never met before, and she didn't know what year it was or who the president was, and that's not too unusual. I asked something that I never asked before, because before, in the nursing home, we would have like a written like checklist of questions to ask every time. I didn't have that in this case. I was just asking questions. And I asked her what her mother's name was, and she couldn't remember. And I thought, I don't know, that kind of made me sad for a second. But, I mean, it was a useful piece of info. Because you got that Reisberg fast scale or whatever for, like, anti-developmental milestones, I guess you could call it. And, this patient wasn't at the point where she could walk. She was having a little more trouble walking, but she was still walking and talking. She just didn't remember anything. And it's always so fascinating to interact with those people, and I really pride myself on filling those interactions with a lot of laughter, and facial expressions are really important, and your body language, and I guess they're important all the time, but even more so when you're dealing with somebody who's memory impaired. And one of the sort of the abstract, higher level, like unofficial kind of instinctual assessments that I do is how easy is it to make them laugh and smile, when I'm trying to gauge what their potential for suffering is. And so I try to promote that. Had a good laugh, shook hands a few times, and figured out what was what and what was going on. Yeah, I hope this project is well received. I hope everybody likes it. I really hope I'm successful in doing it, because if I am successful in doing it, then I'll probably do it more. I'll do some other in-services on some different topics. Or maybe I'll just keep doing this one, and I'll just get better and better at having in-services on ethical dilemmas. That's actually something I wouldn't mind doing over and over again, at least if I was doing it at different nursing homes and, for a limited amount of time, like, a year or two. I mean, who can say if I'll even have this same job in a year or two? You can't really be sure. But I wouldn't mind repeating this in-service multiple times and refining it, and getting good at it. And this will be the first time that well, no, that's not quite true. I've given in-services before, but always one-on-one, never as a group, and always to my coworkers, and never to someone else's coworkers. So it'll be a red letter day tomorrow. This will be a new experience, and I should be able to get some video of it. If not, I'll try to get some audio, but I don't think anybody will object to video. It's only a half hour long, so I can easily upload it to YouTube. Oh, maybe I better ask for permission before I do that. But I'll definitely get the video. I'm just trying to imagine what kind of questions they're going to ask, or how it's going to be received. There's so many variables and how I'm going to approach it is going to be so different depending on how much resistance they put up to the idea that that these ethical quandaries can actually be solved, and that they can have clear-cut solutions to them if if you're communicating. That's always the big thing. So this is going to be a test to see how well I can communicate to them, and how well I can communicate to them, how well they can communicate to other people, and teaching and stuff like that. So I don't know. Hopefully I can pull it off as meta as I had originally intended, where it's a teaching project about the teaching techniques that I'm being taught in my class. That'll be funny to see if I can pull that off. But we'll see. Yeah. Well, I'm back home now. So until next time, tomorrow, I'll drop another episode tomorrow after the teaching project. I'll let you know how it went, and maybe upload a video of the project itself. And until then, have a good whatever it is you're